going to take you through this morning what the plans are for the programme, what administration we expect, what the outputs are, and of course the quality improvements that we hope for. I should say we have a stand just outside number 127. It's just out here on the right. So if you have any questions afterwards, please feel free to come over and talk to us. So this morning what we're going to look at is the background, look at the current status of NPE survey in Ireland, look at what outputs we have, and then what kind of quality improvement we're expecting from this. And we'll take the next 20 to 30 minutes to talk through it. But first of all, what is patient experience? And there's many definitions, but it's Beryl Institute, who are renowned for their excellence in the area of patient experience, say that it's the sum of all interactions shaped by an organisation's culture that influence patients' perceptions across the continuum of care. But I would say to you, currently in Ireland, there's a huge amount of patient satisfaction surveys taking place at hospital and hospital group level. The power of this survey is that it is it's a partnership approach with ourselves in the Health Information and Quality Authority. We're the regulator, with the HSE, who are the operators. They have most of the public hospitals, and with the Department of Health. And therein lies the power. So we will know who we're going out to, we'll know our target population, we'll know our response rate, and we'll be able to do something with the results. We looked internationally, and you can find that on our website, patientexperience.ie, the international review. And what we found was that countries tend to choose the partnership model. Where that wasn't chosen, you don't get the same value for the feedback. You can't make the same strength of what are quality improvements based on their findings. The national survey was an inpatient initially, and then it was followed by other cohorts such as maternity, paediatric, oncology, etc. Questions, highly recommended to use internationally validated questions, because you could spend years coming to agreement on does the question work, and then you need to cognitive test it and so forth. And also the merit of using internationally recognized questions is that you can benchmark, not just nationally, but internationally. Communication has to be robust. We need to tell everybody about this survey program, that it's no surprise for anyone. Hence, we're here today to tell you all about it, and we're just starting the rollout program now. And there has to be huge commitment in terms of capital, operations, finance, and HR from the three partner organisations. And the partner organisations have committed to this capital, to this investment to make this happen. So why are we doing this? And there's huge amount of academic articles, scholarly articles, etc., saying the whys. There's huge benefit to it. And if you think about it, it's kind of logical. Engage in anybody in their care will improve the care that they have, because they feel better when they're in hospital, because they're part of the care, they're part of the discussion, and because once you feel better, it's been proven, I believe, in an article, 1 month after leaving, you're better 9 months after leaving. So it's better all around, better for financial performance of the hospitals, patient loyalty and staff retention improves, a reduced risk of adverse events because patients are engaged in their care, so they know what they should be doing and taking and what should be happening. They're much more involved. They're part of the multidisciplinary team, basically. And there's huge increased employee satisfaction. We expect that there's going to be, while the media tend to focus on negatives a lot, we expect there's going to be an awful lot of positives coming out of here. Most people who do patient experience surveys have huge positive experience once they get in the system. So the benefits from the survey are patients can make a difference to the quality of the care. For service providers, they can identify what area needs to be improved upon. And we're doing a roadshow at the moment going around to all the hospitals in the country. And it's little things sometimes that make the difference. Car parking charges. In A&E, they're providing packages for patients who don't expect to be there. And overnight, they give them like a little pack in Galway. Regulators, we will be able to flag where's the challenges in the system in HICWA, and we can go out and follow that up. But it's just a flag, and it will be used in tandem with other data. And the Department of Health, as the policymaker, will for the first time ever be able to manage and measure if their legislation and policy planning is working. So the purpose of this for everybody is to have the right information at the right time, in the right format, to improve patient care and to make our hospitals and healthcare organisations more effective and efficient. And the greatest beneficiary should be the patient. So what are we doing? We have established a governance structure. We're developing a survey tool. I'll talk you through what we're doing, what the administration of the survey will be involved. I'll take you through an overview of the processes. We're going to test, and I'll show you the timelines as well. So, 3 partnership organisations, 3 very different cultures, huge national project. We had to have a very robust governance structure in place. So we have a steering group, and this is the decision makers from the Department of Health, HSE and HICWA. Phelim Quinn, the CEO of HICWA, chairs this group, and the decisions are all made at this group. The delivery group has myself and June on it, and we're the worker bees, and I chair that, and then we bring what we're doing to the steering group, and they say yes or no to what we've come up with in terms of the model and the methodology. The advisory group is hugely helpful. They help us with the model methodology. They're experts in surveys, experts in national rollouts, includes the CSO and so forth. In all groups, in the steering group, we have a patient rep, Sheila O'Connor from Patient Focus, and in the advisory group, we have 3 patient reps, 2 from the Patient Council in Galway Hospital, and 1 Stephen McMahon. So we are very much front and centre, patient, throughout this project, we make sure the patient is involved. We formalised the partnership between the 3 organisations, and so here you can see the Memorandum of Understanding being signed. So we've got Patrick Lynch, who's the Director of Quality Assurance and Verification and Head of Business and Planning in HSE. We've Phelim Quinn, the CEO of the Health Information and Quality Authority, and Kathleen McLennan, who is the Director of Patient Safety in the Department of Health. And they represent their organisations, and they're on the steering group and the decision makers for our organisations. Each organisation is very clear about their role and their responsibilities. So in terms of Department of Health, they provide directions in terms of policy and legislative requirements. They promote the capture of patient experience across the healthcare sector, and they're going to use the data to inform national health policy and planning. We in HICWA are the lead partners, so we're responsible for developing the model and methodology. We're responsible to make sure that the survey gets implemented, and we provide oversight in terms of analysing the results and benchmarking the reports. In the HSE, there's kind of 2 different levels. There's the national level that are responsible for coordinating and communicating to the hospitals about what's happening and when it's happening and where it's happening and so forth. And then to embed that learning within the hospitals and to help each hospital to learn from their results and to make the appropriate quality improvements as a result of that. We're hugely reliant on the hospitals and looking at them to collate the sample group and to conduct the data quality checks and to roll out the data quality improvements. As I said, patient focus, we have patients throughout all of the different levels, and patient focus represents with Sheila O'Connor the patients throughout the programme, the development and the implementation. So what's the scope of the survey? We're rolling out the survey from May 1st to May 31st. That means any patient that leaves a minute after midnight on the 1st of May to every patient that is discharged to a minute to midnight on the 31st of May will fit into the criteria. Then we further refine by this. It's any patient who's been discharged from a public acute hospital during the survey period, May 1st to May 31st. They're 18 years and over. They have a postal address in the Republic of Ireland, and they've stayed a minimum of 24 hours prior to discharge. Our target population then will be 41 public acute hospitals, and that's across 6 hospital groups. We estimate from the hospital inpatient inquiry system that this will be approximately 27,000 patients. We're asking hospitals to work towards a 40% response rate, which is a huge ask, but we need 40% to have statistical significance. And what that means is that it's a good, reliable estimate of the hospital's population. So there's much more strength in the feedback for the hospitals if they can manage to let their patients know through our communication tools about this and therefore improve their response rate. In terms of developing the survey, we went through an extremely robust process. We purchased last year a library of 189 internationally validated questions from Picker Institute Europe, and many of you may have heard of them. They're experts in this field. They've got questions, their questions are used in 36 countries, I believe. We conducted 8 focus groups, 6 of them with patients, again, throughout the country. And the idea originally for the focus groups was to bring the 189 questions down to a more manageable 100. But actually, when we went out to the patient focus groups, they felt that each question was so important, they didn't want to lose it, and actually they added a few questions. So then we went to the data user groups, again, one in Dublin and one in Cork, and had their feedback, because we need to make sure that the questions that we ask we can actually use for quality improvement. We then did a Delphi study, and this was with about 60 participants, 10 of whom were patients. And the purpose of the Delphi study was to bring that library of 189 questions down to a core of 60 with an additional 40, so 61, 62, 63, so that if for any reason we couldn't use the core, we knew which ones to go to next. Within the Delphi study, we took the findings from the focus groups, so we didn't lose what we found out in the focus groups. We then brought that core 100 to the Picker Institute Europe and went through each of the questions. And we did lose some along the way because they talked about the high ceiling effect or low ceiling effect. The high ceiling effect is where, you're definitely going to get a yes. So therefore, there's no value in the question because we can't make any quality improvements from it, or we don't have any learnings from it. Equally, from the low ceiling effect. So what we wanted was questions that, we can use and we can make improvements and we can learn from. Then finally, we've done a cognitive testing of the survey, and the purpose of the cognitive testing was throughout we cannot change the wording of the questions because we want to be able to benchmark internationally. But the cognitive testing was to make sure the order and the flow worked, the wording worked, everything was completely understood. And we made a few changes there to the cover page, and we made a few changes to definitions. For example, what is a ward, or what do we mean by tests and treatments, so that it was more understandable. And so they are a result of the cognitive tests. And now we're in the process of finally designing the final survey, and we will hope then to move it along, and that has a line under it, and that is complete. There's going to be 60 questions in the final survey tool. 57 of those are structured questions, so that's, were you given enough information on discharge in your care, and that will be tick box, yes, no, maybe, and then we will have 3 free flow questions. And they are supposed to be hugely informative at the hospital level, because they tell you about why the patient thought they were given enough information at discharge, or why they weren't told they were given enough information at discharge, and so forth. So that's the plan in terms of the survey questionnaire. So what are going to be the outputs? We're going to have a national report, which is going to be published by December 31st. And we're going to have hospital group reports, which is going to be published by December 31st. Each of the hospitals will get their own report. We don't plan on publishing it because we won't know, A, if it's a statistical significance, B, this is a huge national project. It's the first year we're doing it. And so we'd like each hospital to gather their own data in the first year. In 2018, we plan to use the data that we found to roll out a quality improvement plan for each of the hospitals and the hospital groups. In terms of communication, there's a lot of communication, as you can imagine, that has to take place. So we're calling it the pre-launch, the go-live, and the post-launch. And the objectives of the communication plan is, first and foremost, to inform staff, because we really need the buy-in and the input of staff. Then to move to the patients and the public, and we do plan on having a public launch in April. We want it as close as possible to the start date, which was go live date, which is May 1st, so it's fresh in everybody's heads. We're also planning on having posters, leaflets, banners, napkins in each of the participating hospitals, so that there will be no element of surprise for patients when they're asked to participate in the survey, and everybody, not just the patients but their families, are aware that the survey is going on. And then we're going to promote the NPE survey and the findings. So what that means is we're going to have a launch of that national report, tell people what we found and the improvements that we're hoping to make. So in terms of the survey, the milestones and the timelines, we have attained ethical approval from the Royal College of Physicians Ireland in January of 2017. We've awarded a contract to a managed service, and what that means is that we have somebody who's going to distribute those 27,000 surveys for us, because the process will be, when the patient gets discharged, they will get an invitation, or they will be told they will be invited to participate. And 2 weeks later, they're going to get a survey pack. 2 weeks later, they're going to get a reminder, and 2 weeks later, they'll get the final survey pack. And it's that final survey pack, the third one, that gets the high response rates. And internationally, we're told it's 50%. The reason we're going with this model is because we have to go postal first, because not all hospitals collect email. But we will provide the opportunity to answer via email or online. And actually, we'd prefer if it was online, because it'll be more streamlined and efficient. But we will obviously provide the postal option. We are conducting a privacy impact assessment, and a privacy impact assessment is where you look at all the risks of a project when you're dealing with personal data and you put in the controls. We've asked an independent authority to do that. We actually have an awful lot of tools and expertise within HICWA on this, but the reason we've chosen to get an independent body is to show that it is independent and it is their own thoughts, and they've met a lot of the stakeholders involved, each of the partner organisations, they've met patients, they've met each of those working or governance groups that we mentioned, and now they're coming out with the final plan, which we will publish. We're conducting a hospital information roadshow at the moment. We've been to 6 of the hospital groups. We're going to Sligo tomorrow, and we have NACE the following day. So we're doing everything we can to make sure we get word out that this is happening, and also to ask the hospitals for a little bit of help, which we're having workshops in the afternoons to go through that. We're planning on testing all of this in March 2017, and the point is that we'll have no surprises come May. We want to be very confident come May 1st that this will work seamlessly. We're going to have the launch event with the Minister in April. As I said, we wanted it as close as possible to the May 1st date, but we have Easter in there, so it'll either be early April or the end of April, probably early April. And we're planning on going live on May 1st. We're then going to analyse the results between July and November, and then publish the results by the end of this year. So that's the summary of everything that's happening. And June is now going to take us through the outputs and our quality improvement plans. Thank you very much.